All right. Well, good afternoon, everybody. Thank you and welcome for our fifth session of the research webinars for the World Trade Center Health Program. We have a lot of great information to share today with Dr. McLaughlin, but we have a few announcements from Dr. Cavalli first, and then we will get along to our presentation. So Dr. Cavalli, we'll turn it over to you.
Thank you very much, Rhonda. Just a brief announcement today. I just wanted to make sure that everybody was aware that on April 26th, we did post a Federal Register notice soliciting input on the scope of our upcoming Lifestyle R21 developmental research announcement. Rhonda will make sure, if you all didn't see that and you're interested in providing comments and insights for that, she'll provide that web location, and you can do that. It closes on May 26th, so next week. And that's all I have. We're delighted to have Dr. McLaughlin with us today, and I'll turn it to Christy Anderson and for the introduction. Thank you, Dr. Anderson.
Yes, I have the pleasure of introducing Dr. McLaughlin. I'm really excited to hear your presentation today. I think it's one of these topics that we're always continuously interested in listening to see if we need to use that research that you bring to us and help inform our operations and our policies. So these are always fascinating, and I think some of these other organ systems that we haven't really operationalized yet, it's the knee bone is connected to the thigh bone, is connected to the hip bone. So we'll see it all come together eventually. Dr. McLaughlin is an associate professor of medicine, population science, and health policy at the Mount Sinai School of Medicine. She is the medical director of the Cardiovascular Health and Wellness, Mount Sinai Heart, and the chairman of the Cardiovascular Institute Clinical Trials Compliance Committee. She's a graduate of Georgetown University School of Medicine and trained in internal medicine at Cornell Medical Center. She completed her fellowship in cardiovascular medicine at Mount Sinai School of Medicine and received her master's in public health degree at Columbia University. Her initial work with the World Trade Center research started in 2008, where she directed the design and implementation of a cardiac screening program, which successfully evaluated 2,500 World Trade Center responders. This study led to the groundwork for her subsequent grants from CDC NIOSH. In 2011, she looked at pulmonary function abnormalities, diastolic dysfunction, and World Trade Center exposure. And then in 2014 and 2016, she looked at renal and cardiovascular impairment in World Trade Center responders. We are delighted to have her here today, and I will go ahead and give the floor to you, Dr. McLaughlin.
Thank you so much. It's a pleasure to be here. I'm here with Dr. Sinai Maceda, who is my right-hand person. I just want to put a shout out to her and let you know that my statistician is currently in the labor and delivery room. So if we have any statistical questions, Charlie, I'm going to have to maybe some of them, if they're too hard for me, we'll have to wait a little bit. And then my nephrology colleague, Dr. Christina White, is in Duke, and she may be able to cut John for a little bit, and we'll thank Dr. Andy Todd is one of our collaborators as well. And we'll thank everyone at the end. Otherwise, I'll be here all day. But I just wanted to say it's been just a pleasure working with NIOSH on these grants. And people would say, well, I'm a cardiologist. Like, what am I doing looking at the kidney? So the way this started was that the first study we looked at cardiovascular risk and found that albumin, the protein in the blood, can seep into the urine if there's some kinds of kidney disorders. And we saw a slight uptake in that protein and decided along the way that would be something very important to look at. So with great collaborators, I've been able to look at the effects of 9/11 on kidney disease. So I have nothing to disclose. And our research questions, we just, to keep it simple, we have three main research questions. And the first one was, is there a relationship between exposure from 9/11 and the risk of kidney damage among our World Trade Center Health Program participants? And is there an association between kidney disease and the well-established World Trade Center related condition, obstructive sleep apnea? And thirdly, what are the possible mechanisms for kidney injury for the World Trade Center Health Program participants? So the prevalence of kidney disease is really rising in tandem with the prevalence of hypertension and diabetes, which are the two major risk factors for chronic kidney disease. But not all individuals with hypertension and diabetes develop CKD, and not all individuals with CKD have those risk factors. But interestingly, the prevalence of CKD has been estimated at 14.8%, but most adults with some degree of CKD or chronic kidney disease do not know they have it. That's what's very important, and it can lead to lots of other comorbidities. There have been studies looking at air pollution and inhaled particulate matter, showing that there is some evidence that increased air pollution effects may be involved in CKD pathogenesis. Also, some studies are looking at the effect of the ambient fine particulate matter on not only just CKD, but the CKD progression. And the proposed mechanisms there are due to four things about the kidneys. It's the high blood flow through the kidneys, the ability of the kidney to concentrate toxic agents, and the high metabolic activity of the tubular cells. Interestingly, the capacity of the kidney to dissociate protein-bound substances makes it susceptible to these environmental factors. We know that significant associations between 9/11 exposure, we just talked about this, on sleep apnea exist, but the kidney disease has not been evaluated in our groups on a large scale. And what I just mentioned about being a cardiologist looking at albuminuria, because albuminuria is a marker of the whole systemic endothelial dysfunction, or the lining of the blood vessels, and early CKD, that's why it's so important. And the issue with OSA, which we've known for a long time, the association with the prevalence in World Trade Center exposed individuals, it consists of several things such as low oxygen or hypoxemia, oxidative stress, and then the lining of the blood vessels again get disrupted, and it causes dysfunction, leading to increased other morbidities. And we know that OSA and albuminuria are both very strong public health risk factors. So findings from our research should address a critical knowledge gap about the risk of kidney damage among World Trade Center first responders and the association with OSA. So when we look at our diagrams of why we think this matters, so the particulate matter in the circulation can have both indirect and direct effects. It can have direct effects on the kidneys, or indirectly increasing that stress and inflammation, oxidative stress, leading to endothelial dysfunction in the blood vessels and the seeping of albumin into the urine, and then renal effects indirectly. Also, we developed a framework linking OSA and CKD. So obstructive sleep apnea can cause chronic intermittent hypoxia, again, with oxidative stress, endothelial dysfunction, and proteinuria, or through the second pathway of sleep fragmentation and arousals, increasing the sympathetic nervous system, leading to glomerular hypertension, hyperinfiltration, sclerosis of the glomeruli of the kidneys, and then chronic kidney disease. And over here, systemic hypertension, inflammation, and interstitial disease. So our specific aims are threefold. One is just to quantify the risk of kidney damage and the relationship to 9/11 exposure among our participants. And we hypothesize that CKD will occur more frequently in our participants in comparison to the general population, and that the degree of kidney disease will correlate with the degree of exposure. And our second aim was to develop a repository of data of the responders who had relatively rare diseases to establish the spectrum of disease compared to patterns of kidney disease in the general population. Because we were hearing about one or two or three participants in our programs that did have some rare kidney disorders. And we wanted to see if that was just random or whether we could find other people with similar diseases. And for aim 2, we wanted to really look at the association between sleep apnea. And aim 3 we really want to go forward if we see an association, or if we did, which we'll find out soon, we want to see the mechanisms. There's so many different types of kidney injury. So is it due to the chronic inflammation, which we know these people can have? Is it due to other toxicities, such as due to the original exposure, maybe to some toxic elements, heavy metals, which may have then sort of precipitated or worked in tandem with other risk factors to cause worsening disease. And then again, we established a registry to look at specific clinical profiles. So in order to enroll our patients, right, so we decided to look at men and women over the age of 35 who were already part of our World Trade Center health programs, regardless of whether they had kidney disease at the beginning. And we also proposed an unexposed comparator group of people who have lived in New York City or worked in New York City, but not in the areas surrounding the Twin Towers. We enrolled 555 participants from November 2017 to October 2020. And unfortunately, we were enrolling our unexposed group during the pandemic, and we had to shut down enrollment. And so we ended up expanding our unexposed group by using NHANES data from that same time period in the same demographics. When it comes to the registry, we enrolled 237 patients. We call it a registry cohort, and we'd like to work with the main World Trade Center registry. Those people we advertised in our programs if patients had kidney disease and if they wanted to participate in our program. And we did receive a lot of people that way. So again, our study was approved by Mount Sinai IRB, so, and it's now completed. So I'm doing a little bit of a medical lesson before we get further on, and this is to talk about what a glomerulus is. It is the filtering unit of the kidney. So you have the kidney, the unfiltered blood just coming in, going through the nephron, which is this right here, and the glomerulus is right here. So that filters the blood, and then the clean filtered blood comes out, and then the urine goes out the other way. So this is why we'll talk about something called the glomerular filtration rate, or GFR, which is a term you see if you get your labs or see your patient's labs that's looking at kidney function. So the GFR we've been using for a very long time, but in 2021, the formula was changed in order to reduce the issue of race as part of the equation, because prior to this, patients of African-American descent or Black race were, the levels were analyzed slightly differently. And in retrospect, it looked like they were being underreported of having kidney disease. So that has changed, and we were able, excuse me, to use the new equation. Now, in order to evaluate that GFR, or estimated glomerular filtration rate, there are three ways to do it. One is based on the creatinine, which is a blood test in the, that we do, everyone gets in their standard blood tests. Then there's a cystatin C, which is another molecule that we can test that more accurately shows early declines in function, and it's not subject to changes in diet or muscle mass the way that the creatinine is. Or the combined creatinine and cystatin C, which is the most accurate estimate of GFR. A normal estimate of GFR is greater than 90 when you see your lab work, but so when we looked at patients with those that were less than 90, between 90 and 60, which was an early sign of kidney disease, or less than 60, which is if you look in their doctor's office or labs, that's clinically relevant. That is showing that your kidneys definitely not functioning up to par. And so we've mentioned that albumin is a protein in the blood. Now we know, you've shown the picture of where it gets filtered. And as part of our protocol, we collected samples of urine for the albumin and the creatinine to make this ratio. We instructed patients to avoid intake of animal protein for 24 hours, to exercise for 24 hours, avoid vigorous exercise for 24 hours, and fast for 8 hours and drink lots of water. And then we would have them come in early in the morning, first random urine sample, and we would check that. And then if that was elevated, we would repeat the ratio a second time to confirm the presence of albuminuria. We also screened all participants to look for other confounders, potential confounders for other risk factors. So we asked all about their medical history, the medication use. We asked whether their smoking history, their family history of coronary disease. We took their blood pressure, their heart rate, their height, weight, waist, and hip and neck circumference. Laboratory evaluations for lipids, C-reactive protein, that marker of inflammation, a CBC, hemoglobin A1C to look for diabetes, serum creatinine, and then cystatin C are markers of kidney function. We also asked the standard questionnaires that our population has gone through, the PHQ-9 for depression, the PCLS for PTSD, and the Berlin questionnaire, the sleep apnea risk score. Sleep apnea testing was used in our patients that tested positive on the questionnaire. They tested strongly positive for having sleep apnea. And then we gave them a home device, and they actually measured their response to sleep. And, and then if they had not been diagnosed with sleep apnea prior, but they tested positive on our test, then they were diagnosed with OSA. So when we were looking at possible injury to the kidney, we looked at urine biomarkers, which I mentioned at the beginning, and there are several markers that we collected pertaining to certain parts of the kidney. So we have the proximal tubule right here. So here's your glomerulus again, your friend. Now we have the distal loop here, the loop of Henle. So we really are focusing on things such as the beta-2 microglobulin, which affects the proximal kidney. Uromodulin function is down here in the loop of Henle. NGAL, which is important for the distal tubular function. We've found some changes there. The neutrophil gelatinase associated lipocalin. Next. And then, as I mentioned at the beginning, we did a robust set of plasma inflammatory markers. CRP, tumor necrosis factor alpha or TNF, and that inflammatory biomarker has been shown to be elevated in both CKD and sleep apnea. We looked at interferon gamma, kidney injury molecule 1, and a whole panel of other cytokines that Dr. Koka helped us with. So heavy metals, we were interested in this, even though it has been many, many years since their exposure to heavy metals. We know that heavy metals like cadmium can be stored in the kidney for many, many, many years. So we did evaluations for lead, cadmium, and mercury. They've all been proven to be associated with kidney damage. What I just mentioned, that the autopsy studies have shown cadmium in the kidneys over decades after exposure. And occupational biomonitoring studies have shown increasing urine cadmium levels with duration of exposure. So this was great that we were able to do bone lead measurements. So because bone lead really, blood lead levels are really recent exposure, but then they can be confounded in people like our group that were many police officers and security officers. So if they're going to the shooting range, they can have high lead exposures due to that exposure there. So the bone lead is a more stable indicator of a prior exposure. And so we did that in over 200 patients. So let's see. Now we'll talk about, we have several tables. Our manuscript is in process, so when it comes out, you wouldn't have to look through all of these tables, but this is just the demographics by exposure group. So showing that there slight differences among age, males, of course, more common. See, education, marital status, work status, some differences. Oh, when we're using the Fisher exact group, it's due to low numbers in certain groupings. Here we looked at baseline medical history by exposure group. Again, it's like, I can't see. Hold on. Okay, here we go. So we can see some differences in smoking rates that are higher in the high exposure. Alcohol. Here we looked at the PHQ-9 depression index, the PCL for post-traumatic stress disorder were not different. OSA diagnosis was higher in the, OSA diagnosis was higher in the highest groups. OSA risk was actually higher in the intermediate group, exposed group. And we have, let's see, and and so in kidney diseases, this was just looking at our registry of different things that we found. So CKD, glomerulonephritis, genetic disorders, proliferative diseases, stones, and other. So the physical measures at baseline, looking through all the different categories of those of very high, intermediate, low exposure, and unexposed. The only real difference here, statistically significant, was the waist to hip ratio and triglycerides. Then we looked at renal function assessment, looking at all the different ways of renal assessment of an unexposed versus exposed. And there was significant difference in renal function as identified by increase in creatinine and serum cystatin C, and those with exposure to 9/11 inhaled particulate matter. Also, we found abnormal kidney function with a GFR compared to unexposed. Exposed had worse kidney function. And we can see that again when we look at those who had a GFR less than 90 or GFR less than 60. Again, it was statistically significant in the exposed group. So now we're looking at the renal function assessment by exposure group. And here, again, the creatinine and cystatin C are significantly different from when we compare the very high group compared to the unexposed. So a creatinine of 1.28 compared to a creatinine of 0.81 is statistically significant, as is the cystatin C of 1.07 compared to 0.77. Oh, I was going to go back. That's okay. So now we're looking at heavy metals and biomarkers by exposure group. And here, as I mentioned, the beta-2 microglobulin is a marker of the proximal effect of the tubular injury, the proximal tubular injury. And then when we have the NGAL, it's the distal tubule injury. So it's a marker of distal tubule injury. So what we found is a statistically significant difference in these two markers of injury. Importantly, an abnormal range of the beta-2 microglobulin is up to 300,000 and ours was over 3 million. So it just gives you the sense of the degree of abnormality that we could see in our cohort. And this is just, oops, sorry. Okay, all right, sorry. We're looking at the demographics when we added the N. Haynes group, so our other control group of 3,300 people. And here you could see that the only differences in the baseline demographics were really males versus females. As we know, our group is more of a, consists of more males than females. Race, our World Trade Center cohort that is more white than the N. Haynes cohort, which was more mixed race. Next. And now we're looking at the difference between measurements of the baseline characteristics was quite small when we added the N. Haynes cohort. There was minor differences in waist circumference and systolic blood pressure and HDL cholesterol. Next. And then when we added the N. Haynes cohort and looked at renal function, we saw a significant difference between the creatinine of the very high exposure and the N. Haynes exposure. Sorry, N. Haynes non-exposure. And looking at heavy metals, importantly, N. Haynes actually did test heavy metals. They tested lead, blood cadmium, and urine mercury. So we were able to compare the two. And there was a difference between the N. Haynes had higher blood cadmium and higher, but lower urine mercury, I'm sorry. Now we're going to look at the World Trade Center patients with OSA and without OSA. So with OSA, we had a higher percentage of males that had OSA. There was no difference between marital status. Work status was, we had slightly more retired people with OSA, and their exposure were quite similar in the with OSA versus without OSA. So looking at other characteristics, we found those with OSA were more likely to report having kidney stones. So those with obstructive sleep apnea, we had 56 participants, or 20%, had kidney stones compared to those without sleep apnea. And when we look at renal function assessment, right, so those with sleep apnea had higher cystatin C, which was statistically significant compared to those without sleep apnea. They also had lower GFRs, but a higher percentage, this is percentage of people with CKD by the CKD 90. So they had higher levels here with OSA. So overall, it looks like OSA influences risk of kidney disease. And here, again, looking at those with OSA and their odds of having kidney disease. When we looked at the CKD 90 using cystatin C equation, it was statistically significantly increased in those with OSA compared to those without. And then, sorry, you adjusted for diabetes and waist to hips ratio. And now we're looking at albuminuria, right? So again, albuminuria is more kidney damage, like I said, leakiness of the protein, compared to what we talked before about the GFR, which is kidney function overall. And here we see the blood lead. First, we'll start with the people who have the urine creatinine ratio greater than 30, that's the abnormal group, compared to those who have the UACRs less than 30, which is what you desire. And these are the, in this group, we see that the blood lead group, the blood lead was higher, statistically significant, but the urine mercury level was lower. So again, this is blood lead, not bone lead, so we're not sure what to make of that right now. But importantly, when we look at those with the UACR greater than 30, that's the abnormal albuminuria, we see the increased numbers of markers, inflammatory markers in the proximal tubular function. These are all higher than those that are lower. And so we're seeing that this may be, associated, this increased inflammation in those who have the urine albuminuria. So now we're looking at, again, now eGFR, or again, the kidney function measured in a different manner. And here we see those people with a GFR less than 90, which is impaired compared to those with a normal GFR. HSCRP, or C-reactive protein, which is a marker of inflammation, is higher. It's 4.99 compared to 3.0. So there's little evidence of maybe increase in inflammation. And there's also increased blood lead and blood cadmium levels in the group with the impaired kidney function by GFR. And when you look at inflammatory markers, again, this is statistically significant differences in several markers, KIM1, beta-2 microglobulin, NGAL, which is very important, and even MCP1, which is a more non-specific marker. But we see, in general, several markers that are higher in those with worsening kidney function in our cohort. So the summary of what kidney diseases we saw in our registered group, we had 237 patients. And when we looked at end-stage renal disease, those with the very high exposure were more likely to have end-stage renal disease. We have kidney stones. Again, this is those with high exposure, very high and high exposure and intermediate exposure compared to low exposure. It's very interesting. And IgA nephropathy. So IgA nephropathy, we could do a whole lecture, and maybe we will at some point, but we would like to do it. We're working on a case report series because we have found 11 patients so far with this IgA nephropathy. Can lead to severe renal impairment and sometimes even renal transplant. We've had at least 3 of those patients had, or 5 of the 11 have had kidney transplants. The fact that we found this, and IgA actually can be immune mediated, and so it's an important potential finding that really may make a difference in the rest of our World Trade Center cohort if we see this. The rates, the occurrence that we found in our small group of over just 237 patients was much higher than expected when you look at the national rates. So that's something we're very interested in pursuing. We're working with the pathologists at Columbia who have looked at the slides, and we're going to be characterizing them in detail and coming up with some more information in this very soon. And so now we're going to look at the registry participants. So remember, so these are the patients that came to us knowing that they had kidney disease. And we know what their exposures are, and on a subgroup of them, not all the 237, but 171 of them did receive testing for inflammatory markers. And interestingly, looking at exposure rates and inflammation, the two things that I've highlighted in red here, the beta-2 microglobulin again and the NGAL, were much higher in the highest exposure groups compared to the lower exposure groups. Those were statistically significant. The other inflammatory markers did not show that. Okay, so participants, our conclusions thus far are that participants exposed to World Trade Center particulate matter were more likely to have decreased renal function compared to the non-exposed. Those World Trade Center exposed individuals who have sleep apnea were more likely to have decreased kidney function compared to those without sleep apnea. IgA nephropathy, which is an autoimmune related kidney disease, was higher than expected. And higher incidence of kidney stones among patients who have OSA compared to those without OSA is a novel finding. One of the anecdotes is when we started collecting patients' descriptions of what their kidney potential problems were, someone asked me, one of our research associates, should we even keep track of kidney stones? And I said, yes, we should, just because we know that there can be some association with exposure to calcium and to even environmental exposures. So I'm glad that we did keep track of them. And kidney stones actually have a high morbidity rate, so patients can get severe blockages and infection, and some patients have lost kidneys because of that, from kidney stones. So it is a more serious problem than gets highlighted in other studies. So we really are happy to move forward with our current data to say that in regards to improving practices of occupational safety and health, that periodic monitoring of kidney function is important in patients who've been exposed to inhaled particulate matter. I do suggest that these findings should impact the current screening and evaluation of World Trade Center Health Program participants. When we talk about limitations, unfortunately, our original comparison group size was much smaller than anticipated. But I think that we made up for it by being able to enhance with an enhanced database that we could match pretty well, and especially with the time frame. And of course, in this type of study, it's a cross-sectional study. So the nature of a cross-sectional study does not allow us to allow for causal relationships to be determined. But these findings should impact, I believe, our current screening processes. Moving forward, I think that it would be prudent to include specific questions regarding kidney disease in the health surveys for this population, especially when it comes to IgA nephropathies or even kidney stones. Again, if we would measure albuminuria, we might be able to pick up early kidney disease that we're not measuring right now in our programs. So I want to thank my co-investigators and collaborators. So Dr. Coca, Dr. Stephen Coca, Dr. Michael Crane, Dr. Rupa Iyengar Kapaganti, and Dr. Christina Wyatt. Our coordinators, actually my lead program manager is Sinai Maceda, Maceda, as most of you know, and Min Jung Kim. And our collaborators, we're really grateful to work with such experts in the field, Dr. Andrew Todd and Dr. Robert Wright. And I'd like to really acknowledge the team of people who helped with this program over the course of several years. And that's Shitra, Mohammed Awada, Christopher Tesaro, Nicolina Isidovic, Gohar Mulisan, Kelly Schneider, and Carol Spencer. And of course, I'm indebted to being able to work under Travis Cavalli and Dr. James and Dr. Cavalli. We really appreciate all you do. And thank you. And if you have any questions, or want some discussion, I'd be very interested in your comments.
Dr. McLaughlin, thank you so much. Appreciate your presentation and the amazing team that you get to work with to get those findings. So thank you. Bye, everybody. Have a great day.
Bye.
Thanks.
Bye. Thank you, Rhonda.